So today we're going to be talking about achondroplasia. Achondroplasia is also known as dwarfism, which is a hereditary skeletal disorder characterized by failure of normal conversion of cartilage into bone that begins during the fetal life. Achondroplasia is a congenital defect that affects 1 in every 25 to 30,000 individuals, ultimately leading to around 250,000 affected worldwide. So you may be asking, what does chondroplasia affect? What parts of the body does it affect? So it actually affects the cartilaginous portions of bones, which form through endochondral ossification of the body. So overall, leading into significant percentage of the human body, this can affect areas such as cranium, spine, chest, pelvis, hips, and extremities of the body, such as arms, forearms, thighs, and legs. So these are the effects that chondroplasia has on the body. All right, so to continue our pathology overview, achondroplasia, as we just talked about, is a skeletal dysplasia caused by the mutation of FGFR3. The FGFR3 is one of the main 4 fibroblast growth factors receptors in humans that influence cellular proliferation. So FGFR3 under normal conditions is particularly involved in areas that give rise to cartilaginous bone, such as the surfaces of chondrocytes. FGFR3's normal function is to decrease the production of chondrocytic bone growth. So it accomplishes this through decreasing the proliferation phase and increasing terminal differentiation. So chondroplasia may affect the body differently in each person, but overall the main underlying identification of achondroplasia is the abnormalities in cartilaginous bone growth. All right, moving on to clinical presentation. So achondroplasia, as we talked about, usually diagnosed at birth, but some typical clinical manifestations that come with this include disproportionate short stature with the normal trunk, shortening of the extremities, bowing of the lower extremities, trident hands, which is just an increased space between the third and fourth fingers, spinal stenosis, and lumbar lordosis. These are all clinical manifestations that occur with achondroplasia diagnosis, and lumbar lordosis is the curvature of the lower spine. So some craniofacial characteristics of this disorder are prominent foreheads, depressed nasal bridge, and a maxillary hypoplasia. Those are some craniofacial characteristics. Some associated comorbidities include clubbed feet and adenotonsillar hypertrophy, which involves the upper airway obstruction. And then later on in life, the average adult height of achondroplasia is approximately 4 feet for both men and women. All right, so the first role modality that we're going to observe is CT. So in CT, some of the risks is there's always a slight chance developing radiation exposure. However, the benefit of an accurate diagnosis outweighs the risk in this instance. The effective radiation dose from CT imaging is about 10 MSV, which is about the same as an average person receives from background radiation in 3 years, which background radiation is natural radiation from Earth and space. Women should always inform their physician or CT technologist if there is any possibility that they are pregnant. CT scanning is, in general, not recommended for pregnant women because of the potential risk to the baby. And then if there is a mother who is nursing, they should wait 48 hours after contrast material injection before breastfeeding. The risk of serious allergic reaction to contrast materials that contain iodine is rare, and radiology departments are well equipped to deal with them if that instance does occur. Children should have a CT study only if it is essential for making a diagnosis, and should not have repeated CT studies unless absolutely necessary. The cost for CT for patients covered by health insurance, typically out-of-pocket costs typically range from nothing to a copay or co-insurance of 10 to 20%, up to $200 for a $1,000 procedure, more than likely. All right, so the second role modality that we're viewing is an MRI. A quick note on an MRI, some items including certain cardiac pacemakers, ICDs, neurostimulation systems, cochlear implants, and medication pumps are acceptable for MRI. However, the technologist and radiologist must know the exact type that you have in order to follow special procedures to ensure your safety. In order to help you with the pre-MRI scanning procedures, it is important for you to obtain information about any implant that you have or may have to provide it to the MRI technologist. So an MRI, the cost is about $1,000 to $5,000, varying on your insurance. And then if you go to the next slide, you can see that MRI has no radiation, so that's actually a benefit over CT. Even though it's a little bit more expensive, that also will help kind of make a decision for most people, especially in kids. Allows measurement of foramen magnum, which is very important to diagnose this disease, and then excellent delineation of neural structures. Okay, so on this slide, you can see that we have some images of a fast MRI. A fast MRI has low specificity, it has high sensitivity, and subsequently leads to full MRI, but it's very expensive. All right, so right here we have diagnostic radiography. So this image is inexpensive, high sensitivity, it has low specificity, and low radiation dose. And you can see more so of the bony structures in this image than you can the MRI. It looks kind of translucent. The computed tomography, this has no sedation, one of the faster exams that we do provide. The cons of this type of image, though, is its substantial radiation dose. It's very expensive, and it almost always is followed with an MRI just because it doesn't show specific details of things that we're looking for. So our modality of choice for achondroplasia is ultrasound. Because this is a congenital condition and fetal ultrasound is the modality of choice and keeps with the ALARA principle, as this modality does not expose the patient to radiation. Typical features which can be found using ultrasound are frontal bossing of the forehead and macrophthalmia, or enlarging calvarium, depressed nasal bridge, hypoplasia of the midface, where the center of the face develops more slowly than the eyes or the forehead. Also, short limbs and the trident configurations of the hands, which we talked about a little bit earlier in this presentation, occur. It may be difficult to recognize typical prenatal clinical features until the third trimester of pregnancy, though. So in patients where there is a diagnostic uncertainty or atypical findings, genetic tests from the amniotic fluid may be required to identify a heterozygous pathogenic variant in the FGFR3 gene, which is previously mentioned in the PowerPoint presentation as well. Yeah, so we hope you enjoyed our presentation over achondroplasia, and if you have any questions, feel free to email us. On slide 12, we have our references listed out for you. So, thank you.